Welcome, everyone, to this episode of the Journal of Clinical Anesthesia's podcast, where we highlight noteworthy articles from each issue. I'm Julian Ressler, Assistant Social Media Editor for the Journal and your host for today's interview. I would like to offer a really warm welcome to Professor Savino Spadaro, the lead author of an article from our September issue titled Impact of Early High-Flow Nasal Oxygen on Diaphragmatic Function and Pulmonary Complications After Thoracic Surgery, a randomized trial. Thank you so much for taking the time to talk with me today. So let's start with a short introduction. Savino, could you tell us a little bit more about yourself and your role in this study?
Hello, everyone, and thank you for the opportunity to discuss our work. My name is Savino Spadaro, and I'm Associate Professor in Anesthesia and Intensive Care at the University of Ferrara, and where I also coordinate clinical research activities in perioperative and critical care.
All right, welcome. So let's get right to some questions. Could you briefly summarize your study, specifically explain the main objective of the study and what were the key findings?
Yes, and our main objective was to test whether early application of high-flow nasal oxygen after thoracoscopic lobectomy could reduce the incidence of diaphragmatic dysfunction and postoperative pulmonary complication. We conducted a single-center randomized controlled trial, including 116 patients. The motivation of our trial comes from a well-recognized clinical challenge. After thoracoscopic surgery, diaphragmatic dysfunction is a very common and is a major driver for postoperative pulmonary complication. This complication prolong hospitalization, increase the need of respiratory support, and are a key determinant of outcome in lung cancer surgery patient. While conventional oxygen therapy, low oxygen therapy prevent hypoxemia, it does not address impaired in terms of respiratory mechanics. High flow nasal oxygen, on the other hand, has several physiological effects, such as reducing work of breathing, generating mild positive and expiratory pressure, and improving gas exchange that could, in theory, protect the diaphragm and mitigate pulmonary complication. Our main findings were that high-flow nasal oxygen did not reduce diaphragmatic dysfunction or postoperative pulmonary complication overall compared to standard oxygen, but in patients who did develop diaphragmatic dysfunction, high-flow nasal oxygen clearly lowered the risk of postoperative pulmonary complication. We also observed a modest but significant reduction in hospital length of stay in high-flow nasal oxygen group.
Oh, thank you. So congratulations on the great study you did. You mentioned your trial did not show a reduction in diaphragmatic dysfunction or overall postoperative pulmonary complications with high flow, yet patients with diaphragmatic dysfunction seemed to benefit. How do you interpret this specific subgroup effect?
This is indeed a crucial aspect of our findings. We observed that high-flow nasal oxygen did not prevent diaphragmatic dysfunction, but once diaphragmatic dysfunction was present. High-flow nasal oxygen seems to attenuate its negative impact on postoperative pulmonary complication. Physiologically, this makes sense. After thoracic surgery, the diaphragm is weakened by surgical trauma, anesthesia, and altered chest mechanics. In this vulnerable state, even small increases in workload can trigger postoperative pulmonary complication. High-flow nasal oxygen reduce work of breathing and provide a mild PIP effect, and improve oxygenation. Mechanism that can stabilize the patient whose diaphragm is already impaired. So, while high flow nasal oxygen may not be a preventive tool for all patients, it may be most effective as a target strategy in those who develop early postoperative diaphragmatic dysfunction. This highlights the relevance, the importance of bedside diaphragmatic ultrasound, which can help identify at high-risk patient and guide the use of high-flow nasal oxygen as a protective rather than preventive therapy.
No, that's great to know. And the other thing you said is that you observed a shorter length of hospital stay in the high flow group. Do you believe this difference was clinically meaningful, and what mechanisms might explain it?
Yes, the absolute difference in length of stay was modest. 4 days versus 5 days. I believe it is still clinical meaningful in thoracic surgery. Thoracic surgery, every additional day in hospital carries consequences. It increases the risk of nosocomial complication, delay access to other therapy for cancer patient, and generate additional healthcare costs. So even a 1-day reduction has both clinical and economic relevance. Mechanistically, there are a couple of explanations for this effect. Firstly, high flow nasal oxygen, patient experience fewer severe pulmonary complications such as hypoxemia and the new infiltrate. Preventing these events likely accelerated the recovery and reduced the need for escalation for respiratory support. Secondly, high flow nasal oxygen may allow an easier and more consistent weaning process than conventional oxygen therapy. Patient can maintain stable oxygenation and comfort. The comfort for the patient is very important, in particular in postoperative patient, which support early mobilization and progression along enhanced recovery after surgery. A shorter hospital stay is not a marker of fewer complications, but it also impacts on patient experience. For patients undergoing lung cancer surgery, yearly discharge translates into faster return to normal activities and potentially early initiation of oncological follow-up treatments.
Absolutely, I absolutely agree. And you already hinted a little bit at this, but given that high flow did not prevent the diaphragmatic dysfunction in the overall population, but might mitigate its consequences, which patient subgroups do you think we should prioritize with high flow after thoracic surgery?
Oh, that's a great question. It goes right to the core of how our findings apply to clinical practice. Our trial showed that high flow nasal oxygen does not prevent diaphragmatic dysfunction, but it does appear to mitigate its consequences. It suggests that not all patients need high flow nasal oxygen, but there are a subgroup in whom it may provide a significant benefit. And I'm thinking that firstly, patients who demonstrate early postoperative diaphragmatic dysfunction on ultrasound are the most obvious target. In our trial, those patients experienced fewer pulmonary complications if they were managed with high flow nasal oxygen compared with conventional oxygen therapy that use a low flow of oxygen therapy. This highlights the role of point-of-care diaphragm ultrasound as a tool to stratify risk and guide therapy. Second, patient with reduced preoperative reserve before surgery. For example, patient with chronic obstructive pulmonary disease, chronic smokers are more likely to develop dysfunction and could benefit from unloading effect of high flow nasal oxygen on the diaphragm. Third, our exploratory analysis suggested that the patient with a lower baseline oxygen level seemed to benefit more, making this subgroup to prioritized. In practice, high flow nasal oxygen may be more effective when applied selectively in thoracic surgery patients. Targeting those with impaired diaphragmatic excursion or higher baseline risk could help focus its use where it may have the greatest impact. Looking ahead, high flow nasal oxygen could be considered within personalized postoperative care pathways using single bedside tool such as the diaphragmatic ultrasound to guide respiratory support. This approach may help move from a uniform strategy to one is more tailored and patient-centered.
Very good. It's something we can definitely all consider incorporating in our practice. Savino, this already brings us to the end of the interview. Thank you so much for taking the time to talk with me today, and congratulations again on your very interesting study.
Thank you very much for the opportunity to discuss and share our interpretation of the result of our paper. Thank you very much, and hello everyone.